I'm Dr Jenny Noakes. I'm the designated radiologist, senior radiologist at Breast Screen, Northern Sydney, Central Coast. And this talk is about what happens in breast screen to women after they've had their mammogram, the QA processes that go on, and clinical scenarios and case studies. First of all, I'll start telling you about us, and importantly, the difference between screening versus diagnosis in breast imaging, how we manage women with symptoms, what's involved in the screening process and the assessment process, our reviews that we undertake regularly, rescreening women, and then the case. So this is us. Breast Screen Northern Sydney Central Coast is composed of the blue Northern Sydney local health district area and the Central Coast, the brown area. We extend from the harbour up to Woy and from the coast into Ryde. We have a mixture of fixed sites for screening, and also we have some mobile vans that travel around. We're really trying to increase our number of fixed sites. That seems to be more acceptable to the women, in preference to mobile vans. And recently we've opened up a site at Brookvale, and more recently, just in the last few weeks, a site at Charmhaven. So who should attend for breast screening? Our target age group is women 50 to 74 years, and we actively recruit these women. We have various means of doing that through the electoral roll and phone calls, and we send reminder letters when their next screening mammogram is due. So that's usually every 2 years. Any woman 40 or over is eligible to attend, but women between 40 and 50 and women over 74 need to initiate the appointment for themselves. So we don't actively recruit them, but they are very welcome. They do need to remember to make their rescreening appointment so they don't get the reminder letters that the target age group get. So we have a large population. Women in our area, in the target age, we had 181,000 women in a recent financial year, 2018-2019, and approximately twice as many women in that target age in the Northern Sydney area compared to the Central Coast. And our participation rate is about 52%, which is quite a bit lower than you would like for a screening program. Usually we like 70% or more. But we have to remember that most of these women, it's not that they're being neglected. A lot of women are having a pseudo screening process privately. There are some women out there, though, who probably have had no breast imaging that we do want to encourage to attend breast screen. In Northern Sydney, we have the highest incidence of breast cancer in New South Wales. So our standardised incidence of breast cancer is about 1.17. We think that this is due to socioeconomic reasons. That seems to be the most likely explanation, but it gives us a bit more impetus to be encouraging women to undertake breast screening. A recent study has been published in Radiology that shows the beneficial effect of having consecutive screening mammograms. So we all know the benefit of having a screening mammogram and having an early breast cancer diagnosed. But this is a nice graph showing the beneficial effect of sticking with it and having consecutive mammograms. So the red line here is for women who've never had a mammogram. This is increasing mortality up the side here, and then years down the bottom here. The green line is women that come regularly to breast screen, every time their mammogram is due, and you can see their mortality is about halved compared to women who have no mammogram. And then the two lines in the middle are interesting. The yellow line is lapsed participants and the blue line is intermittent participants. So these are women who have missed one of their two last screens. So they still have, interestingly, they still have some benefit incurred from having had regular screening mammograms, but it's not as good as if they stuck with it. So in Australia in 2020, our participation rate dropped considerably because of COVID. Our services were suspended from March to May because of, well, as you're all very aware, because of the lockdown, and there were concerns about PPE at that time. So this graph is showing 2018, so 2 years before. We work in the 2-year cycles of mammograms. And the light blue is the participation across Australia in breast screening and screening mammograms. And the dark line, the darker blue blackish line, is 2020. And you can see that we were doing very well with participation pre-COVID, and then dropping to zero, and then climbing back up and actually making up a little bit of lost ground here in September. But there is still quite a big shortfall to catch up. There was 145,000 less mammograms performed in that time period, January to June 2020, compared with 2 years prior. So we did catch up a bit by about 12,000 mammograms, but certainly our service had another impact on our participation with the Northern Beaches lockdown. And this is a graph showing New South Wales screens and target screens and participation. So the red is in target, which is what we were supposed to achieve. And you can see with us here, Northern Sydney Central Coast, we were awfully close, and we were about to achieve target, but then the Northern Beaches lockdown came and affected us. But still, you know, a reasonable recovery in that time, but we still haven't caught up for the backlog of missed mammograms. And right now, as I speak, we're in another lockdown, which is certainly affecting participation. So women are really self-culling and choosing to go to smaller screening sites rather than sites in bigger hospital venues. So we have COVID safe measures. Of course, we follow the New South Wales health advice. There's regular check and questions on arriving at the building. You can't enter the building unless you go through that process. There's cleaning of all the surfaces and equipment in between women, and extra time is allowed for this. All the clients and staff have regular hand hygiene. We have the hand sanitizer, and staff use that and regularly wash their hands between clients. We're using masks for all clients and all staff. And we also reduce our client numbers and stagger appointments so that there aren't too many people in the rooms at any one time. And we do ask that companions either don't come or wait outside. We do have a separate waiting room at St Leonard's for assessment clinics, so companions can wait outside, or we encourage people to have a coffee and come back in a little while. There has been some alteration to the technique for the mammograms with the radiographers. They've been trying to use a new technique that minimises closeness, particularly for one of the views, the CC view, where they end up being quite close. So they've made that adaptation. And our waiting room is very minimalist now. We've taken out all the superfluous things, and there's you know, very, very clear social distancing is in place. So who should not come? We're big on encouraging people to attend, but there is a group that should not come. So women with significant symptoms. So if there is a new palpable lump and it's concerning, then they really need to have a diagnostic workup and not be investigated with a screening mammogram. High-risk women, for example, young women with a genetic risk factor, they should be attending a high-risk clinic and not coming to breast screen. Any woman who's had a mammogram elsewhere in the last 12 months, we won't see them until after that 12-month period. And any woman with a breast cancer diagnosis in the last 5 years, because they're best managed, they need more than what we can offer at breast screen. They need closer surveillance, so they're best managed by their treating team and GP, and then we're very happy to see them after the 5 years. So there's two different pathways in Australia for the investigation of breast problems. So breast screen is really for asymptomatic women, and women are eligible for the screening mammogram through breast screen funding. So that's separate from Medicare funding. And the screening is to look for an occult small cancer before it's palpable, and it doesn't specifically investigate any symptoms. So that's in contrast to the Medicare funded pathway, which is for symptomatic women, and that investigates the cause of the symptom and is funded through Medicare for mammograms, ultrasound and biopsies. And streaming the women in this way provides better care for the woman and also better use of the health dollar. So the difference in the imaging side of things, so in screening, as I said, we're looking to detect occult cancer. We do standard 2-view mammograms of both breasts, and we compare with any prior films that are available. So we hang the films compared with the second most recent prior round, so we're more likely to see any change, but any priors are available for the radiologist in packs to review as they need to. Women are recalled for further assessment of any suspicious area, and benign changes, while we notice them, we don't recall for them, and they're not reported in the letter. So it's all about cancer. We're either concerned or we're not. As opposed to the diagnostic pathway. So the aim of the diagnostic pathway is to find the answer for the symptoms that the woman presents with, and that clinical symptom is pursued until there is a diagnosis. So standard 2-view mammograms are performed. They may have tomosynthesis instead, and they may have extra views if needed. So, magnification views for calcifications perhaps, and they can have ultrasound, and they can go on to have biopsy and possibly other tests, and that's usually at a separate appointment because it's not able to be anticipated what's going to be required until the process is started. So how do we manage symptoms in breast screen? Of course, women do come to breast screen with symptoms, and we don't shut the door, so we don't want to turn any woman away from a service. We don't want them to put up with a symptom and not be investigated. So we do ask them when they attend what symptoms they have, and we do, if there's significant symptoms, we do recommend that they see their GP and postpone their screening mammogram. But if they don't want to do that, then we will do them anyway, and the radiographer will give as much information as possible to the radiologist who's reading the film. So you can see here there's a breast diagram, and they can mark in this case, they've marked in a lump, and they've given us a bit more information about it. It's for about 2 weeks. She hasn't seen the GP. She's explained that the breast screen results do take a couple of weeks, and that the woman is happy with that. So the symptoms recorded, and if the radiographer feels like it's a significant symptom, so sometimes the symptoms that are recorded are pretty vague, but in this case, with a new lump, that would be flagged for the radiologist, which means when you're reading, this flashing light comes up, which is pretty hard to ignore. So here's an example of where the radiologists reading the films have taken note of the symptoms. So you can see up here, we've got the reader 1, they write their comment, reader 2 writes their comment. They've both commented that the woman has a symptom in the area where they've noticed a change. So they've said probably cysts, so there's lots of lumps in this breast, but they've made a comment, specific lump in the area of interest. So the specific lump was probably, this cyst. But in this case, there was this irregular cancer just sitting superficial to the cyst, which was the palpable area. It's not far deep to the skin surface here. So, thankfully in this woman, by paying attention to the reported symptoms, we were able to make that diagnosis. So if a woman reports a symptom and they're not recalled for further assessment, a letter is automatically generated to the GP, and I'm sure you've seen these letters. So we're obliged to notify the GP of any symptom that's reported. So if it seems insignificant to the radiographers, and there are many insignificant, unusual seeming comments that they get, they do try and discourage them, triggering an official letter with the label symptom. But if the woman wants to record something and wants it reported, then the letter is automatically generated. And of course, any significant symptom, the letter is generated. So I'm sure you've seen those. So our screening mammograms, there's a standard 2 views of each breast, and I'm very pleased to say we have state-of-the-art equipment across our entire service, and it's all the same equipment. So from a radiologist point of view, that makes a big difference, being able to have the same look of image when you're comparing, current films with prior films, and when you're reading across different sites. So, we don't just read from one site, we read from all the sites. So it makes a big difference if we've got the same equipment. There's a lot of QA in breast screen. Our radiographers undergo a lot of QA with their performance. They're critiqued on positioning and the number of repeated images that they do, and they have regular upskilling and training. So each screening mammogram is read independently by 2 radiologists, and all of our radiologists have a subspecialty expertise in reading mammograms and in breast imaging. So if they don't agree on whether a case is normal or whether it should come back to assessment, it goes to a 3rd radiologist for arbitration. So the 3rd radiologist is usually a very experienced senior radiologist making that decision. So 2 radiologists must agree before any woman is recalled or any woman is rescreened. Our radiologist readers all have a subspecialty expertise in breast imaging, which may be a fellowship that they've done in breast imaging with BreastScreen, or it may be accumulated experience. And before working in our service, they have to prove their worth and do 500 trial reads, which are evaluated against senior readers in the service before they're able to commence. And all of our radiologists must read a minimum of 2,000 mammograms every year. It doesn't have to be with this service, it can be with any of the BreastScreen services in Australia, but it must be through BreastScreen. And all of BreastScreen reads are audited and radiologists are given feedback. So feedback to radiologists on any missed cancers, any recalls they made that were rejected by the third reader, explaining why it wasn't brought back to assessment, and any interval cancers that we're notified of, we let the radiologist know. We also give continual feedback as it arrives. So, for example, women that we send for surgery, we might get some surprising or interesting results back, then I'll feed that back to our radiologists. And I must say, we do give them good feedback as well. So far, we've just talked about, the fairly negative feedback, but there is good feedback as well. If they were the reader that picked the cancer, they get feedback about that as well. And we provide formal performance statistics. So, every 3 to 6 months, the number of cancers detected and how that compares with BreastScreen requirements and past performance and other radiologists. It's anonymous, of course, the other radiologists. But it's a very helpful way to learn and improve your performance and maintain interest in the work that you're doing to get all of this feedback. There also is quality improvement programs that we can put in place if we need to. So if for whatever reason a reader's performance drops, we usually know fairly quickly and can institute a quality improvement plan, after discussion with them and something, of course, that's appropriate. So this is what our images look like. We hang the current round on the top. So we've got the two MLOs there, right and left, and then the two craniocaudal views. So the MLO or mediolateral views you can recognise because they've got that triangle of pectoral muscle at the top here, and comparing it with the second most recent previous round so that we can detect changes. So what do you do as a GP after the screening mammogram if a patient presents? So sometimes a patient or client presents with a symptom before you've got the result of the screening mammogram. So they've attended and then they've noticed something and they come to see you. So it really is, I think, important once the BreastScreen process has started that it is continued till you get a result from BreastScreen. So I'm not saying that you should wait if you're really worried about this symptom. If you can call here and talk to one of our counsellors, we can fast track the reading of the mammogram and any appointment if the lady's coming back to BreastScreen. But we have had, it is difficult if they've started the BreastScreen process and say that we want to recall them and then they go somewhere else. They may not necessarily get that area evaluated fully. It may not be appreciated. Anyway, I'm sure you can imagine there's lots of room for miscommunications if the process isn't completed and information communicated. So if the woman has a normal mammogram result and a symptom letter, then we'd just like you to evaluate the symptom really as you best see fit. The normal mammogram isn't saying that there's nothing there, it's just saying that we haven't seen any signs of breast cancer. So some cancers are occult, and if it's a concerning symptom or a new symptom, I'd encourage you to get an ultrasound and perhaps some further mammogram imaging as needed, as I'm sure you would do. If the lady is recalled for assessment after our reading process, we would really like her to keep the appointment so that the area of BreastScreen concern can be evaluated and determined if it's significant or otherwise. I think it's very hard for someone else to evaluate something that's been recalled if they don't have all the information, and sometimes these signs are quite subtle and I think I've made my point. I think we really would like the woman to keep ongoing with the BreastScreen process once it's been started, but we're happy to fast track, if it's needed. If the woman develops a symptom between screens, then that would be, the ball's in the court of the GP to manage that as appropriate. We are very welcoming of any feedback, of any significant findings of cancer in women that we've seen at breast screen. We'd be very grateful for that. So in our service, we do have a culture of quality performance, and everyone works hard to do their best and improve. As I said, we have up-to-date equipment and we have up-to-date knowledge as well. We're lucky to have a team that is really interested in breast imaging and breast cancer treatment, and they're really it's at the top of their game. I think a lot of the surgeons that come here are front runners in neoadjuvant chemotherapy as a treatment for breast cancer, and the radiologists that work in our service come from all over Sydney. Actually, they're experts in breast imaging in various hospitals and private practices around Sydney, and I'm sure you recognise many of their names when you see our assessment letters. We have dedicated subspecialty breast pathologists, and they attend our MDT meetings. And we have an enthusiastic group of fellows, both radiology fellows and also surgical fellows that come to the clinic. So the assessment is led by the radiologist. It's a radiology screening program, and the clinical team is led by the radiologist. We have quite a big team. We have a counsellor that sees the woman in the beginning and consents for the assessment, explains everything to them, and if they need a biopsy, they will explain that beforehand and explain any post-biopsy treatment and arrange the giving of the results and support ongoing after that. The radiographers perform the workup views, and in our service, it's bilateral tomosynthesis. So, tomosynthesis is just such a wonderful way to be imaging the breasts, and we offer that to both women bilaterally, even though we're just recalling usually for the one side. But women can decline that offer if they wish, but I think that's really the best service we can provide. So we offer that, and in the time that we've been doing it, be for about 4 years now, I only know one person who hasn't wanted bilateral tomosynthesis. We do additional views, spot views as needed. So all calcifications really need magnification views. You cannot see them well enough to analyse their possible cause and the level of suspicion without that. So the radiologist reviews the mammograms, orders any extra views if needed, performs the ultrasound. So we don't have sonographers in our service, so it's a radiologist performing the ultrasound. The surgeons take a history and perform a clinical exam, and then the radiologist and the surgeon discuss the findings and correlate the findings. So we want to know if the surgeon can feel anything in the area that we're interested in, but also if they can feel anything else that we may need to follow up with review of the tomosynthesis images or an ultrasound of that area. Then if a biopsy is needed, that's done by the radiologist, either under ultrasound or tomosynthesis guidance. I think the beauty of this is it's all done in one session. The women have to wait a little bit to get into the clinic, so the results can take a couple of weeks. But once they come to the clinic, they see a counsellor, radiographer, radiologist, surgeon, and can have a biopsy. So if we need the pathologist to come over, they'll come over. So it is a good service that is provided at the assessment clinic. So this is some of our team. You can see behind our team, there's a board at the back. So we write the women's name up and we follow their progress through the clinic so everyone can look and see, what stage that woman's up to and what might need to be done. And the women are kept informed, the whole way through, what was the result of this step and what is the next step. And we answer any questions as far as we can as we go through. The biopsy results do take about 3 working days, and particularly now where additional stains and testing is done on the core biopsy, if there's significant pathology there, they can take a little bit longer to come back. We do like the women to come back to breast screen so that we can explain the results, or to go to their GP and have their results from the GP if they prefer that. And in that situation, we have some breast physicians that work for us as well, and they're able to ring the GP and give them a heads up and explain the results from the breast screen point of view and answer any questions. I would say the exception for that is benign results. So if we get a clearly benign result, like fibroadenoma, no concerns, then we will ring the woman and give her that result over the phone to save her an unnecessary trip to come in again. So looks a little bit complicated to start with, but it is quite straightforward, our way for progressing women through our assessment. So they have their full assessment workup, and if that's normal or benign findings, then they have a routine 1 or 2 year rescreening. Most women have 2 year rescreening. If it's equivocal, suspicious or malignant, then they go on to biopsy. If that's a cancer, then their GPs are notified and they go back to the GP for the surgical referral. I think that's an important part of our program. I think other services in New South Wales are quite different. The breast screen program tends to refer to the surgeons, but we like in our service to refer back to the GP, to keep the GP involved in the management of women, and also, for the GPs to discuss with the woman, which surgeon is the best for them, and to take charge of the next step in management. So sometimes the biopsy result isn't that straightforward. We can get an atypical result. For example, atypical ductal hyperplasia is a not uncommon result to get on biopsy of calcifications. And sometimes the results are not concordant. So we might have something that we're quite concerned about and we get back a core result that says normal breast tissue. So clearly discordant. So those results go to our weekly MDT, which is a group of senior radiologists reviewing those results. For ones that we need pathology input, we'll involve the pathologist as well. And we come to a group decision about the next best step. So if it is sufficiently concerning, either on imaging or pathology or both, then it will go to diagnostic open biopsy. What we try to do in that meeting is to be sure that there is significant reason, because we don't want to be sending women for unnecessary surgery. So in the past, if there was any mention of atypia in a core biopsy report, the woman tended to go and have that excised. We're trying to minimise that because sometimes the atypia is very insignificant, very minor in size or severity, and can come down to a difference in the opinion of different pathologists. So we really don't want something that's that iffy to have unnecessary surgery. Sometimes these days with our biopsy techniques, we remove the whole thing. And so if we're confident of that and it's not suspicious pathology, then we have an MDT discussion about whether we can just keep an eye on this. The other option we have is early reviews. So we might get a woman back to assessment clinic in 4 to 6 months' time. That can be if we're not entirely sure that something is abnormal or not, or it can be if biopsy wasn't possible, but it wasn't worrying enough to send to surgery. So we've got a few different options. So we do have a weekly assessment review. And so this is senior radiologists reviewing any cases with discordant results, atypia, or where a second opinion is needed. So particularly, for new people starting, it's nice for them to use this, I think, just to get a feel for how the service thinks and how we manage things. But smart, experienced radiologists will also send things for second opinions. Our pathology MDT is a monthly meeting. We are trying to make that more frequent at the moment, and I think we've succeeded. So that's good news from our results timeframe for the women. And this is senior specialists. So this is we have a surgeon, a pathologist, and radiologists attending this meeting, and we review anything that's discordant or unusual or anything that has incomplete information. And this is where we make the decision about atypia. Is it significant or not, enough to go to surgery or not? We do review any of our women that go to surgery. So we review all of those cases to make sure that what we were worried about breast screen is what's been operated on, and get that feedback on what the outcome was. So this is an example of a 52-year-old lady. It was her first screen, and she had some scattered calcifications, but 2 focal clusters. So they're usually pretty hard to see calcifications, but it's just this little cluster here that you can see. And she had 2 of those clusters. So They were both biopsied using our vacuum biopsy technique, and one cluster was benign proliferative change, and the second cluster was benign, but it did have a 1 millimetre focus of ADH, atypical ductal hyperplasia. So when we're doing the biopsies, you can see here we x-ray the tissue to make sure that we've got the calcification that we were targeting. And we also put a clip in afterwards. So you can see we've got two different shaped clips here. And this is so we know where the biopsy came from. And also if we do happen to remove the calcification, it's a marker in case that woman needs to have surgery of that area, or in the future if it's relevant to look back and see where the biopsy was taken. So this particular case, it was reviewed at MDT, and it was concluded that the ADH was completely excised at the core biopsy. So there were no residual calcifications, and it looked like the ADH was all within that area on the pathology, and it was small, 1 millimetre. So these women go for annual screening. So that's from now on, once we've made the diagnosis of atypia, it's annual screening. And with these women, the MDT team will make sure that they review the first mammogram to make sure that there's no change, basically. So how do we decide if someone should have 1 or 2 year rescreening? Well, most women have 2 year rescreening. If there's a strong family history, we're using the FRABOC online tool to evaluate that. If there's significant atypia on biopsy, if they have a personal history of cancer, so if they're after that 5 years of treatment of cancer, then they are on annual screening. We do have an option of a temporary 1 year rescreen, which we can do after assessment if we've got low concern, but we just don't feel comfortable for waiting for 2 years to be sure. So this can be if we've done a biopsy, we've got calcifications, but we would have liked more, but we didn't get more, but it's not worth going back for another biopsy. So those sorts of situations, we will do a temporary 1 year rescreen. The routine 2 year rescreen, that's most women, and we would really like anyone that's over 70 to be on 2 year rescreening unless they have a personal history of breast cancer or atypia. So when is it safe to reduce from 1 year to 2 year screening? I would say we're still waiting for information on this topic. But what information we do have suggests that it's after the age of 60, the increased risk associated with a family history of breast cancer does reduce to population level at that age. So we are actively reducing our annual screening due to family history in women over 70 years. So we're leaving ourselves a bit of a leeway there. And that may come down even further in the future, say down to 75. But at the moment, anyone 70 years or over, it's our preference that they're on 2 yearly rescreen. I just point out, like the family history within breast screen is not that high risk family history that that women are seen outside of breast screen for. So the increased risk associated with atypia or personal history of breast cancer does persist, but it does reduce with age. I think it's unclear at what age it would be safe to put these women on 2 years screening. So we keep them on 1 year rescreening until we get some good evidence to guide us in that. Another point to make is that screening benefit is not proven in women over 74 years. And in these women who have, say 10 years or less life expectancy, they're probably better off doing health promotional activities than screening. So in terms of benefit versus harm, screening may not be the best thing for them to do. We certainly wouldn't turn them away. And 80 is the new 70 and 70 is the new 60. So we keep our doors open, but it's, I think it comes down to women's general health and what's best for them individually after that age. This is the article that's helped inform that information about the reducing risk of family history with age. So that's there if anyone's interested to look into that further. So the strengths of breast screen, well, I think the assessment provides expert information to the women with imaging and clinical exam and biopsy at the one visit. The surgeons don't have a vested interest, and all patients are referred back to their GP for surgical referral. There's quality assurance of all aspects of the clinical work through multiple review processes and performance feedback. And Breast Screen is a large conservative organisation. It's got inertia to change, but that does give us a robust structure, and it does have strong governance. So the weaknesses, contralateral ultrasound is not routinely provided at assessment. So we do an ultrasound of the area we're interested in, or of that whole breast, and that's an individual radiologist's decision. The individual radiologist at clinic might decide that they want to ultrasound the contralateral breast, which is perfectly fine, and we're very happy for them to do that. But because we don't have sonographers, we don't have the capacity to do bilateral breast ultrasound on everyone that comes to clinic. So the contralateral breast does have tomosynthesis, which is very reassuring. Being part of Breast Screen, there's a central control of our information letter that we sent out. So many of us would like to change that letter that you receive, which is a bit clunky. And we are working on it, but it's a really slow process. So as part of being a large organisation with inertia to change, it is slow to change. And even for reasons that we think are important, clinical reasons for change, it is very hard to affect that change. And I think, breast density is a topic that I think virtually every radiologist would like to see breast density reported at screening, and I'm sure the GPs would like to receive that information. But at the moment with Breast Screen, we can't do that. We also don't have tailored screening for different levels of breast cancer risk. So I think that will come in the future. Some people might be fine on 3 years, and some people need 1 year, which we are doing to a certain extent. There's a criticism of Breast Screen by epidemiologists about overdiagnosis. So my thoughts on this is that we're not overdiagnosing, so we need to know what's going on. So if there's an area we're concerned about but we're not sure, we need more information. So we need to do a biopsy, or we need to do an early follow-up to have the confidence in the outcome. So I think what the problem can sometimes be is overtreatment. So and I think that's where MDTs help. There's a consensus about what is the best way forward with this particular pathology in this particular woman. And I think that's a very sensible approach. And if you ask most women, they would really like to know what the cause of this thing in their breast is that you've called them back for. So I don't think they would buy into an overdiagnosis argument. We do try and minimise harm. I think an example of that is what I mentioned about minimising unnecessary surgery from Breast Screen findings. So with breast density reporting, increased breast density above the mean does increase the relative risk of breast cancer by about 1.2 to 2.1 times the average risk. So I'm sure you know this, and I'm sure GPs would very much like the information about women's breast density. The Breast Screen Australia position statement says that there's no agreed, consistent, reliable measurement method of breast density, and that is true. There's no consensus on how to optimally manage breast density, also true. And even though breast density can mask cancers on mammogram remains the most effective screening test for breast cancer, and that is also true. We are able to report breast density in assessment, so you might see on some of our assessment letters that breast density is being reported. We do, as a radiologist, take into consideration the breast density when we're reading the mammogram. So that's part of our screening mammogram and assessment evaluation. And I would say that if we're not sure and the woman has breast dense, then they get a recall. Supplemental screening, there's a bit of new information out on the value of supplemental ultrasound, and it seems to be less and less valuable now that we have tomosynthesis. So a good study has shown that there's no benefit to supplemental ultrasound in average risk women with non-dense breasts following tomosynthesis mammography. So these are asymptomatic women. There's a modest incremental cancer detection by screening ultrasound in women that have dense breasts after tomosynthesis, but it does not outweigh the harm caused by additional false positive findings and biopsies that are triggered by those false positive findings. So the move now is for contrast-enhanced studies, because contrast-enhanced mammography and contrast-enhanced MRI is better at ultrasound to detecting these additional cancers but also it detects the more physiological concerning cancers, because the contrast is how vascular is a lesion, how quickly does it take up this contrast, and cancers, and particularly aggressive cancers, take up the contrast quickly and become quite evident on these newer tests. So I've got some cases to show now. This is a 52-year-old lady. She came to breast screen for her first screen, and she was recalled for this little cluster of calcifications, which you can see the circle around them there. And this magnification view shows you the cluster of calcifications, which are a little bit variable, a little bit irregular, and they're different in density within the cluster. So these were biopsied, and we've x-rayed the cores to confirm that they were biopsied. And we've put a clip in to show the location. And this came back as high-grade DCIS. So she had a normal physical exam, which we do before the biopsy for obvious reasons in all the women that are at our assessment clinic. And with these impalpable lesions, it's very important that they have a hook wire localization and specimen imaging. So we need to show the surgeon, where the calcifications are so that they can follow the wire and take them out. But we also really need to see that they've got the target. So here you can see they've got the calcifications and they've got the little clip. And this is a joy to breast screen radiologists to see this. So we can be confident that the area that we were concerned about has been removed. And I think it's really important that we have that confirmation. So we review all of these cases to make sure that it's all concordant. So this lady did have a close margin and re-excision, and her total amount of DCIS was 17 millimetres with no invasion. And her treatment was a wide local excision with radiotherapy and endocrine treatment. This was one of our regular screeners, a 62-year-old lady, and she developed a subtle new density, posterior and inferior in the right breast. So the current mammogram's at the top here, and it was this density that caught our eye. And if you look on the previous films, there's nothing back there in that retromammary fat. This is an area that we particularly attuned to, the fat at the back of the breast, which is a not uncommon site for cancer to develop. And it's pretty tricky on this view. It's just this little bit of density peeking in at the back there. So you can imagine that would be easy to overlook. So tomosynthesis pulled the breast out more, and you can see the density better here and here. And on the tomo picture, it is a bit irregular and spiculated. This was not palpable. Ultrasound, quite subtle. I think this ultrasound, like there is some central darkness and shadowing, but the size of the lesion is this sort of bright echogenic area around it. And you can see that if you follow the normal tissue planes, they suddenly stop. So they're interrupted by this lesion. It's the same on the other side. So that's a helpful sign that we use when looking for subtle cancers on ultrasound. So this was biopsied under ultrasound. A clip was placed, and then we do a post-biopsy mammogram to confirm the clip position, and also to confirm that the ultrasound lesion and the mammogram lesion are the same, that we only have one cancer, not two cancers. So this was a small invasive cancer. It was 10 millimetres invasive duct cancer, grade 2, and there was some DCIS with it. The sentinel node was negative, 0 out of 2 sentinel nodes. So this lady had, her treatment was a wide local excision with adjuvant radiotherapy and endocrine treatment. So this was another regular screener coming every 2 years for screening mammograms, and she developed some new calcifications. These were quite subtle to see, within all of these tissue, with these sort of patchy tissue, nodules as well that were stable. So a few distractors and very subtle calcifications seen, which I'll show you better on the magnification views. So on these views, you can see they're a bit concerning because they're lining up. So that makes us think that these calcifications are traveling along, within the ducts, and we're worried when we see this appearance that it's DCIS. There's also a bit of background density you can see here, a bit of irregular tissue with the calcifications. And I think the tomosynthesis confirms that nicely. It's shown a little stellate lesion in association with the calcifications. So these were biopsied. It was under tomosynthesis guidance, and as usual, we've x-rayed the cause and shown that we've got calcifications, and we've left a clip, and you can see left a little hole as well as the clip marking the spot. So the core biopsy showed invasion as well as high-grade DCIS, and at excision, she had 7 millimetre invasive cancer, grade 1, and 30 millimetres of high-grade DCIS. So as is often the case, the DCIS at pathology is more extensive than what we can see at imaging. She did have 1 positive sentinel node and no positive axillary nodes. She had, to help in the management, she had the EndoPredict test, which showed that she was high risk. And because of that, her treatment was wide local excision with chemotherapy, radiotherapy, and endocrine treatment. This lady was a regular attender for annual screening. She's 59 years. Now, she'd had a previous calcifications biopsied on the right side, and a clip was left in, and that showed atypical lobular hyperplasia, which didn't require any further treatment, but she was put on annual screening for that. And it does place her at higher risk. So any diagnosis of atypia increases the likelihood of the woman developing breast cancer, which is why we put them on annual screening. And on this mammogram, she was recalled for some distortion on the left, which was here, and also some calcifications. So the calcifications are this little circle here. So they're in the medial part of the breast, and this distortion was lateral. The calcifications are quite irregular on the magnification view, so they were concerning and underwent biopsy. The distortion really didn't persist on tomosynthesis. The calcifications came back as high-grade DCIS, and she came to MDT review, and I'm hoping that this tomosynthesis will run, yes. So you can see, I think, why we like tomosynthesis. We can scroll through it, and it eliminates the problem we have of overlapping breast tissue to a large extent. And it also can show unsuspecting additional areas. So I'll just try and stop this at the right spot. And I think you can see this stellate lesion here with these radiating spicules sort of pulling into that central area there. So this was an unsuspected second area of persisting distortion that was concerning, that was found at MDT review. And this lady was brought back for a second biopsy, and this was invasive cancer. And it was a mixed ductal and lobular cancer. So it was quite large when she went to excision. It was about 40 millimetres and a grade 1 cancer. And she also had high-grade DCIS with that, and 3 positive axillary nodes. So quite a lot more disease than we were able to demonstrate on the mammogram, but we did show that it was multifocal, and that was very helpful in the decision making. Because, often with multifocal disease, particularly with lobular cancers, they will have an MRI to look for additional disease, which she did have, but didn't find any additional disease. She did undergo mastectomy, and she had chemotherapy, post-mastectomy, radiotherapy, and endocrine treatment. This is a 54-year-old lady. This was her second screen, and between screens she developed a new mass, which you can see here at the tissue fat interface of that breast. Physical exam was normal. We always ask ourselves, is there anything else? Like finding one thing, if you find one thing, there could be another. And she did have a second lesion. So tomo nicely shows this irregular mass, but it also shows this pulling in here, this stellate appearance again with radiating spicules in that breast. So circled here. So 2 lesions, both look concerning on ultrasound. So this has got this dark lobulated lesion, has got that bright cuff of reaction around it, which is, the body trying to contain this cancer, and the cancer infiltrating into the adjacent tissues, interrupting those tissue planes like, we saw on a previous case. Whereas this is the stellate lesion. This is a more typical appearance for a stellate lesion. It's not that well defined necessarily, but it has that shadowing from all the fibrosis, and you can see it's irregular margins and spicules. So 2 cancers found here. A third one was also found, and she had an MR which found an additional cancer. So multifocal disease and, fairly aggressive looking cancer. She went to MDT discussion to decide on the best treatment for her. Should she have neoadjuvant chemotherapy or should she go to surgery? So because of the more extensive disease on MR with an additional invasive focus, she had a mastectomy followed by chemotherapy, Herceptin and endocrine treatment. So this is the last case. This is a 68-year-old who was a regular attender for 2 yearly screening. And you can see that she's developed this new mass. So it's a fairly large mass to develop in 2 years. And it is worrying on tomosynthesis. So it's quite dense. It's got a bit of a tail here, fading off into the tissue. And you can see this sort of string of calcifications sort of heading towards the nipple. So all of these features are concerning. The ultrasound, at a casual glance, you might think it's a cyst, but when you look at it closely, it's quite irregular. It's not a cyst at all. It's not well defined. It's got that echogenic rind around it like the other cancers that we've seen, and it's got stuff in it. It's got these little spots of stuff. It's not a cyst. It also has a little satellite nodule next to it. And typical of cancers, it's deeper than it is wide. So benign lesions tend to be flat and horizontal, sort of blending in with the orientation of breast architecture, whereas cancers are vertical and invade and have no regard for the normal architecture. This is a high-grade lesion. It's a grade 3 lesion, and they tend to have less body reaction, so less fibrosis around them. They tend to be round masses that just sort of push out into the tissue uncontained. So this was a high-grade invasive cancer, and she was treated with neoadjuvant chemotherapy first. And there's good data on the use of neoadjuvant chemotherapy in terms of better treatment of the cancer, but also in terms of better surgical cosmetic results. So she had a complete radiological response after her chemotherapy, and then went on to have surgery. And it's also shown that the neoadjuvant chemotherapy can increase breast cancer survival. So I think that's becoming more frequent these days. That's it from me. I hope that that's helped understand a bit more of what goes on behind the scenes at BreastScreen. Look, we're really grateful for your support in helping women come to BreastScreen and have their mammogram, and for your help in managing the women after their mammogram. Thank you.